Thanks for joining everyone. And today we'll talk through left ventricular dynamic obstruction. As always, please, ask questions as we go along. We'll see how we go. So I think this is an important topic for the Crit Care DDU because it's something that happens not infrequently, I think, in ICU with critically ill patients, and often it leads to a complete U-turn in our management. And what I mean by that is if you've got someone with rapidly escalating pressors, um, you might be tempted to add in more vasopressors, second line agents and things and often it's the opposite thing that we need to start doing if we recognize LV outflow obstruction. Some good articles that I think I've talked about before obviously we're not going to cover everything today, so always good to do a bit of background reading on this stuff. So we'll go through how to recognize if there is obstruction and then have a little bit of think about how severe the obstruction might be. That's more of an outpatient thing, like in terms of like when you might intervene and offer ablation or myectomy. I guess in the ICU, any form of obstruction is obviously, can be catastrophic for patients. So, but there are some numbers, I guess, to be aware of for exams and things. And then how to locate the site of the obstruction. And I'll talk through some of that. So not, you can obstruct in the like intraventricular obstruction, in the apex of the LV, in the mid cavity of the LV, or you can obstruct at the level of the outflow tract. And we'll talk through how you might differentiate some of those. Really important to be aware of certain caveats, like how to differentiate a dynamic left ventricular outflow obstruction from a mitral regurg trace and things like that. And then just briefly cover what we might do when we find obstruction. So firstly, is there obstruction? I think the first thing to say is that it isn't all about hypertrophic obstructive cardiomyopathy, and that in our patient group, we see this quite frequently with patients that have septic shock, hypovolemia, particularly prominent in Takatsubos with that basal, hypercontractile state and that apical ballooning. That lends itself to, certainly a risk factor for developing dynamic LVOTO. The same reason that's the case with large anterior MIs in particular. And then post-valve surgery, particularly mitral valve repairs, where you have an increased propensity of pulling that mitral valve over and blocking the outflow tract. So I think we need to be suspicious, in anyone that has unexplained shock or rapid escalation in pressor requirements. There are certain anatomical factors that predispose to developing dynamic outflow tract obstruction. And it, as I said, not the patients don't have to have HOCM. So things like having left ventricular hypertrophy, small LV cavities, sigmoid septums. I'm kind of thinking of those, elderly female patients in particular. This loop that's playing now is a small elderly female where they have these big atria, often have these small LV cavities and sigmoid septum from their chronic hypertension, and they're sitting ducts for developing LVOTO if they get urosepsis or something. Hypertrophic cardiomyopathy, of course, is a big risk factor. One that we don't seem to think about so much is those with sort of right heart failure, pulmonary hypertension, with cor pulmonale, when that septum is then pushed across towards the left, obviously reducing the space there, and crowding around the LVOT. And then, predisposing again to outflow obstruction. And then in any mitral valve abnormalities, particularly having an elongated anterior mitral leaflet, in some congenital things, and you often see mitral valve and subvalvular apparatus abnormalities in HOCM as well, which we'll talk through. And then, sometimes you have patients that have a relatively normal heart and then they just get rip-roaring septic shock, like this patient here down the bottom, for being underfilled and very vasodilated, they'll develop obstruction. So lots of groups where, it can happen that we need to be aware of. So just briefly, how does the obstruction happen? There's a fair bit on this, like a bit of a change of thought. It's not all from the Venturi effect, essentially. And there are leaflet abnormalities that lead to ultimately a failure of coaptation and a pushing of that anterior mitral leaflet towards the septum and blocking the outflow tract. So there's usually like these, slightly elongated anterior mitral leaflet, and sometimes there can be anterior displacement as well of the mitral apparatus, and then the like the pap muscles too. So there are sort of anatomical things that happen, and in systole you have like the first thing that happens is your posterior leaflet sort of pushes your coaps with your anterior leaflet, but then the posterior leaflet tends to then push across onto the anterior leaflet, and it sort of pushes it towards the septum. And then because you often have this slightly redundancy in your anterior leaflet, that can then be again pushed more by the vortices in the blood flow. And then you get that sort of push and suck effect from Venturi. So there's probably a few things going on. So it's not all just Venturi forces. You do have these sort of push forces as well due to the anatomical changes. And you can read more about that in papers like that one where I got that picture from. And there probably is some element of the Venturi effect as well, leading to that systolic anterior motion of the anterior mitral leaflet. So that's kind of how it happens. As I said at the beginning, it's not all about HOCM, but obviously sometimes we do, see decompensated HOCM patients. This is the most common congenital cardiac abnormality that we see. It has a prevalence of about 1 in 500. It is, of course, a diagnosis of exclusion when you've ruled out other secondary causes, hypertension, aortic stenosis, infiltrative things. Athlete's heart sort of always comes up as a DD for hypertrophic cardiomyopathy, particularly in young athletes, obviously. And a wall thickness of more than 15 millimeters in the absence of a secondary cause is consistent with a diagnosis of HOCM. And if there is a positive family history, a strong family history, then more than 13 millimeters. So there's different variants of HOCM as well. It's not always the Ashford variant, the asymmetric hypertrophy of the septum. It's not always that you see that. We can get obviously big sigmoid septums, what they call reverse curve HOCM, as well as apical HOCM. And I feel like it's not common apical HOCM, but we've had a few cases come through at Nepean, and sometimes they're easily missed because you can't always appreciate the hypertrophy at the apex. They do have characteristic flow patterns, especially if they have an outpouching and an apical aneurysm, which we'll talk through how that might look on Doppler interrogation. But you do need to be suspicious for this if you're seeing, thickened walls towards the apex and you've got evidence of cavity obstruction. Not just if you're not seeing that classic HOCM, which I'll show you on the next slide, remember that there are other variants because, sometimes we can overlook apical HOCM, and it's obviously a topic in and of itself, and there are other features on clinical and ECG and things like that you would look for. I just wanted to mention that in these patients, it can be helpful to give contrast, as you can see down at the bottom here. You can see this hypertrophy at the apex. Once contrast really helps it just pop and you can appreciate it. You can also sometimes appreciate the apical aneurysm as well. That can come along with mid-cavity variant HOCM and apical HOCM. And you might have heard of that ace of spade sign that you get with apical HOCM as well, because of the way it looks like a spade inside the ventricle. So why might I have put 50 millimeters of mercury on the screen? Does anyone want to talk through why that might be significant, this sort of talk?
That's when the gradient of obstruction becomes clinically relevant, is it?
Yeah, it's when they start thinking about intervention. As I said at the beginning, I think that's that's in the guidelines and things for outpatients with HOCM. I think in our patient group, any gradient is significant because it does impact their acute hemodynamic management. But yeah, 50 is what the number is in guidelines in terms of defining obstructive physiology, and then whether you might go on to have other interventions. So you can either have that as a resting gradient, and the patients I suspect will be pretty symptomatic if that's the case, or you can get them to do provocative things like Valsalva's, and exercise testing. Obviously, don't recommend doing dobutamine stress echoes for these patients because even my heart, like a normal heart, undergoing dobutamine stress can sometimes develop outflow obstruction, like that loop I just showed with that septic patient. So they tend to avoid dobutamine and to provoke a gradient, they tend to do exercise stress testing instead. Anyway, so 50 is a magic number for when interventions might be considered, like ablation or myectomy. Should talk a little bit through. So this was an 18-year-old that came into our outpatient clinic, was having pre-syncopal episodes. Just point out a few things. You can see the parasternal long axis. You can see this huge, very thickened anteroseptum, and even without measuring out, it's definitely, it looks to be over 15 millimeters. He's also got a small cavity. You get the suggestion that there's probably not, there is some sort of SAM, but probably that it's not, doesn't look like it's happening. It doesn't look like there's full septal contact in systole there at rest, is there? But you'd be worried about SAM developing there because of the size of the septum. There is a small pericardial effusion as well. And with colour on, we can see that there is flow acceleration. I'm just going to slow that down for you. So we can see as blood is being ejected from the LV into the LVOT, you can all see that flow turbulence there. So important to train your eye to that happening. He's a bit tachycardic, this patient as well. And, you need to then be interrogating a bit more, could there be obstruction? There's the short axis, again, showing that he's got concentric hypertrophy, hasn't he? But it's asymmetrical. So he's got the variety, and he has got HOCM. He's got the asymmetric hypertrophy of the septum variety of HOCM. Let's play that for you there. You can see this big asymmetrical septum. So his gradient at rest, this is using, we'll go through this in a bit more detail, this is using continuous wave. You can't really get up to velocities that high with a pulse wave, so we know it's continuous wave, and by the spectral appearance as well. And he's got a gradient. You can see, can you appreciate, does anyone know, well, you do, I know you all do. How would you describe the appearance of this spectral Doppler trace? What's the buzzword that we use to describe it? You got it, that the dagger shape, so that late peaking jet, or that dagger shaped jet. And it's not the best one, fair enough. It's but you get the idea that it has got that sort of dagger, sharp point, sort of late peaking appearance. Not the best trace, I agree. And at rest, the gradient here was 32. So generally when you're getting above 30 as well, that patients might start to be symptomatic potentially with that. I haven't got what happened with provocation for him, but I think they probably did go on to do provocation. I don't know whether his gradient then went above 50. So let's dig into it a little bit more then. So we'll just go through it step by step. I realize some of you are very new to this. Some of you would be able to do this presentation better than me, so it's a bit of a mix. So please, just chip in, and if I say something wrong or you've got something else to add, please do that. So some classic features. So we talked a little bit about them. So the classic thing on 2D is to look for that systolic anterior motion of that anterior mitral leaflet. All right, so I'm just going to slow this down so you can see it. And it can be a little bit tricky, I think, when you're first starting to notice this. But basically what I do is I look at when the LV cavity size is getting smaller. And then as I see that getting smaller, I look to see whether the LVO, the outflow tract is crowded or not. Like, is there something in the outflow tract as my LV is contracting? So if I just do this slowly now and see that LV coming in, you can see as the LV is coming in here, I'm getting some septal contact during systole. All right, so it's a train, and you can see how it's there. You see it's just bending into that, and that's the thing as well. Like that, as I said about that anterior mitral leaflet, there's often abnormalities with that as well, like redundancy, slight anterior tethering of the pap muscles and things that sort of lend those push forces and sucking forces for it to touch during systole. So you can just see that there, just coming in systole. You can see that there's contact. You see that? Can you all appreciate that now? We're in systole, and that there's septal contact with the anterior mitral leaflet. It's easier to spot on a parasternal, I think, than it is on a four chamber like that previous one, unless it's really obvious. So here we have someone with concentric left ventricular hypertrophy, who did also have HOCM. This was a patient that was in our ICU with decompensated HOCM. And you can see here, right, I'm just going to go through it really slowly. As that LV is coming together, the cavity is obliterated as well. I'm just going to show you again. You see that as the LV is coming together, we've got crowding in the LV outflow tract, and we have got septal contact. Your septal contact doesn't have to be throughout the whole of systole. You can just have some partial contact in a little bit of, that's non-hollow systolic or whatever, like, so it's not through the whole systolic cycle. But if there is some septal contact, you're still going to have alterations to the blood flow out through the heart. So what a good thing to do, a good tip, is to put M mode through this, and that allows us to have better temporal resolution. We can really see what the anterior mitral leaflet's doing. So here we have the anterior mitral leaflet in diastole. It's not the best slice through, but usually we would have that E and A wave of the mitral leaflet in diastole if they're in sinus rhythm. But we can see in systole, this should, this leaflet should just be nice and, flat down here. What we can see here is the anterior leaflet is moving and hitting the septum. So this is the septum here, and this is the anterior mitral leaflet, and it's touching the septum. Certainly on this beat it is. It's kind of almost touching. It's certainly moving towards the septum in this one. Not quite hitting the septum in this one, and in this one again not quite hitting. So it is intermittent. That's probably some of the non-perpendicular alignment with the M mode trace as well.
Emma, is there a particularly good spot to put the M mode cursor for getting that profile?
Yeah. Just put it down through, cutting through the septum, and then down through your anterior mitral leaflet. So sometimes just swinging the heart up, so you've got your anterior, so you can just a little bit like you would just do for your LV measurements if you're using M mode for that, and just make sure that the cursor is cutting through the anterior mitral leaflet. So sometimes that little bit of rocking of your probe to bring sort of the LA like right into the center of the screen, then allows you to line up perpendicular with your cursor.
Cool, thank you.
The next thing we can do is we can use color Doppler, and that can help us identify whether there's turbulent blood flow, essentially, increasing our suspicion that there's obstruction through the LVOT. So we can see that here. I might just, again, this that first loop I was showing, I might just slow that down. So we could see on 2D that there was contact during systole. Let me just start from a cycle. So just finishing diastole, coming into systole now, you can start to see there in systole that we have this aliasing. Variance is on, unfortunately, sorry about that. That's the green color. Anyway, there's aliasing of blood flow, so lots of turbulent flow at the outflow tract, in keeping with what we're seeing on our 2D features as well. And then what we can see is this. Does anyone know what we're seeing there and want to explain the mechanism of that? So we've got here, we're getting obstruction. Yeah, so we've got all that turbulent flow when the obstruction's happening, and then something else is happening just after. So there's this phenomenon of obstruct, eject, obstruct, leak, right? So you're pulling that anterior mitral leaflet across, and that anterior mitral leaflet pulling across, it's almost behaving like an anterior mitral leaflet prolapse. So what you then get is this classically, you get SAM related MR, which is classically posteriorly directed eccentric mitral regurgitation. Yeah, if you're seeing anything that's not eccentric and posteriorly directed, then you've probably got a mixed pathology for your mitral regurg, and then you need to go looking for, you know, other mitral valve pathology, because classically SAM related MR will be posteriorly directed because of that obstruct, eject, obstruct, leak phenomenon. This is another example. I just, again, slow that down for you all. So we've got blood flow coming in, diastole, and then we've got systole happening, lots of turbulence at that sigmoid septum, we've got SAM happening, we've got obstruction, and then we're leaking some posteriorly directed mitral regurgitation. Can you all appreciate that? Eject, obstruct, leak. And this is clinically important for us because this patient actually, with this huge left atrium, big raised left atrial pressures, pulmonary congestion, worsening mitral regurg, but LV going like the clappers, right? So this patient needs to have, like, obviously stopping their inotropy, and giving them little aliquots of fluid, which seems really counterintuitive if they're in pulmonary edema. But it's the only type of MR where giving fluid will actually reduce the pulmonary edema. That's one of the reasons why I love echo, and I love this topic, because it just absolutely gives a, you know, you do a U-turn on your management. You know, so you've got a patient there who's hypoxic in pulmonary edema, and you're thinking, oh, I need to, like, give them furosemide, right? And you actually put the probe on, and actually what you need to do is give them 100, 200 mils of fluid and see what happens. And with this particular patient, little aliquots of fluid reduce the obstruction, reduce the leak, reduce the MR, reduce the pulmonary venous pressures, reduce the pulmonary edema. So I think that probably sums up why I love this topic, because it really changes patient management. Dagger shape profile, which you talked about, that late peaking dagger shape. And you can imagine, right, you're getting all that blood being squeezed through your LV outflow tract. You're going to get that late peaking dagger profile. So with this type of dynamic obstruction, it obviously looks different to a fixed obstruction to your aortic valve, which tends to have this parabolic shape to it. So important not to get fixed obstruction. Obviously, I'll show you some cases. I think I'm going to show you a case of a patient that has fixed aortic stenosis as well as HOCM and dynamic obstruction, who was really complex to manage. Yeah, so important to know the distinction between them. So severe AS, we tend to see this parabolic profile, like rounded You can see the difference there. Whereas with dynamic obstruction, it's this dagger shape. And then finally, which I've actually already skipped onto this and talked about it, is that SAM-related eccentric MR. And I think this is from Chris's paper that showing that SAM-related MR that we talked about. And this is one of the videos that we put in that paper, which is that eject, obstruct, leak phenomenon, just showing a nice sort of textbook posteriorly directed MR, zooming in on a parasternal there. This is a still frame of it showing it. And then this is a still frame of the M mode showing that systolic anterior motion, the mitral leaflet. All right, any questions so far? I might get you guys to do some talking now. Is that all right? So do we have any volunteers? I think there's only about 2 loops or something on this one.
Yeah, I can start just as an exam practice.
Good on you. Right, go for it.
Yes, I'll just read the stem first. A 60-year-old COPD on BiPAP. Background of hypertension, COPD, and pulmonary hypertension. And she's coming with wheeze, hypotension, and cold peripherally. Okay. And on noradrenaline, adrenaline, and rapidly escalating inotropic requirement. So this is a apical 3-chamber view. I think the most salient finding is hyperdynamic LV. And sorry, if you don't mind playing the loop again.
Sorry, yeah.
And there is a suggestion of SAM as well, but I'd like to interrogate this further. Sorry, my dog. With Doppler analysis.
Yeah, so I might just slow that down for everyone. This is almost like caudal SAM, isn't it? Because it's the chordae that are attached to that anterior mitral leaflet. I mean, it is the anterior mitral leaflet as well, but you can see there in systole, there's absolute contact, isn't there, between some of the subvalvular apparatus as well as the anterior mitral leaflet against that big bulging septum. Nice. So what do you want to see next, Hewan?
So collar Doppler across the LVOT. Yeah. So there is significant flow turbulence suggest in the LVOT. In fact, also probably at the mid-cavity level as well, suggestive of obstruct or increased gradient and obstruction. And there's also eccentric MR jet, posterior no, that's not posteriorly, that's more anteriorly directed. MR jet as well.
Yeah. It's good that you've spotted that was anterior, because it's unusual, isn't it? You definitely want to see that in more views, because you would be thinking, oh, could I? So if you see then, like what you think is SAM and outflow obstruction, and you see an anteriorly directed jet, what might that want you to look for in your next, like throughout the study?
I mean, as you said, the first thing that comes to mind is there a coexistent mitral valve pathology?
Yeah. So what would give you an anteriorly directed jet?
Oh, well then, I mean, you could get like restricted movement, like the posterior leaflet pathology would give you anterior directed jets, or like restricted posterior leaflet motion, like for example from like ischemic MR.
So
I'm not sure the specific example.
Yeah, no, it's a good. So a restricted posterior leaflet in ischemic MI, you're exactly right. That's when you tend to see it. It gives you a posteriorly directed jet, because it hugs along the wall, like from that posterior restriction. But a posterior leaflet prolapse gives you an anteriorly directed jet, because of the Coanda, the Coanda effect.
Yeah.
How it
you're right.
Keeps onto that curved surface and then goes round that direction. So you might then think, oh, could there be like a posterior leaflet prolapse in this patient then?
Oh, sure.
Yeah. Or is it just that they've got degenerative MR because they've got a bit of thickening of the mitral valve, and they've got some anteriorly directed MR as well, like centrally directed MR, sorry, from that. Or anteriorly directed. So yeah, I mean, there might be I don't think this lady does have prolapse. Anyway, I digress. What does you got the key things there, and that's really good. I guess just one thing to say about the color Doppler there is that maybe just make sure that the scale isn't up too much. You see how you've got this speckling in the LV wall there? You probably just
Oh, sure.
want to reduce the gain, sorry, of the Doppler, of this color Doppler, just to make sure you're not over gaining and get rid of those speckles on there. And then the other thing is just always eyeball the scale that you've got set. Make sure you're not at something silly like 20 or something.
Yeah.
If someone's left that setting on or whatever. But yeah, this is 56, so it's on the lower end, isn't it? But it's still an acceptable scale to see that there's obstruction. All right, what can we see here? There's quite a lot going on here.
Yeah, so that's continuous wave across the LVOT in apical 5 chamber, I think. And I think there is probably multiple, well, I see at least 2 waveforms. So the late peaking dagger-shaped jet with a peak velocity of 2.87, with a gradient of 32 is the gradient from LVOT obstruction. There's also the more parabolic waveform that has a higher velocity must be across the aortic valve, and that's also quite like increased at almost up to like 4 meters per second. So the patient may have like a separate fixed obstruction.
Potentially, yeah. I mean, I haven't actually shown you the aortic valve too well, hey. So there could be, it doesn't look, well, you need to see more views. But the other thing that you could be catching there, what else might it be?
Oh, so it could be like an MR jet as well, isn't it?
Yeah, exactly. So it's you, and I'll show you some more profiles, but this is a real problem because you get MR contamination, because, often you've got SAM-related MR as well, and it can be really, really tricky to differentiate dynamic left ventricular outflow tract obstruction and dynamic MR from SAM, because both of them tend to have this mid to late peaking velocity as well. But there are a few ways that you can, and I'll show you them in a bit. And maybe there's some like intra-cavity gradients as well, maybe up here, but you can't see them that well in this particular trace. That was really nice. Yeah. I guess just like technical point, you might just reduce the gain of the spectral Doppler down a little bit. It might just help you, try and delineate those gradients, because it's a bit overgained, isn't it, that background? It's a bit too bright. All right, do we have another volunteer?
Hi, Emma. I'm happy to have a go, but I'm not very far into exam prep.
That's all right. Yeah, no, go for it. Thanks, Zoe.
So 74-year-old man, community acquired pneumonia, shock, normal angiogram, catecholamine rising. You've shown me a apical 3 as well as a para-apical, like a subcostal kind of view.
Yeah, they're not very good views. Sorry about that.
No, that's all right. In the obvious abnormalities is some segmental systolic dysfunction, and it's morphology within the setting of this normal angiogram makes me worry about the Takotsubo syndrome with a ballooning of distal apical segments as well as the akinesis of apical segments. With that, there is almost this compensatory hyperdynamic motion of the basal segments. Although I can't pause and see the LVOT very well, but it makes me worried about thank you. I think there's some contact of anterior mitral leaflet to the septal knuckle, and makes me worried about a dynamic outflow obstruction.
So what would you do next in this patient, Zoe, if you just had those 2D pictures?
Yeah, so it's really tricky. You'd almost be tempted to inject some beta blockers only at the basal segments and catecholamines elsewhere. I think on balance, you probably will still try some small aliquots of fluid and a repeat assessment to see ideally the separation of the anterior mitral leaflet from the anteroseptal wall.
Yeah, nice. But what other echo techniques do you have? So like you've got your 2D features there, but obviously you want to try and put as many pieces together to increase your probability, right? That this is what you're dealing with. So what other techniques do you have? your
So I'll put
toolkit.
a color flow Doppler through that. You've shown me a continuous wave here, which
Yeah,
is a
nice.
late peaking dagger shape with a peak gradient around 2.5. So definitely elevated gradient at rest. And the morphology of the spectral Doppler is in keeping with a dynamic obstruction.
Yeah, really nice. I agree. It's got that. It's not the best tracing, is it? And the 2D images are not the best, but sometimes this is all you've got, and you've got an acutely deteriorating patient in front of you. And so, you know, sometimes you've got this, you've got a bit of color showing that turbulence, you've got a continuous wave jet showing that late peaking dagger shape, and you know, you can be saying, let's give 100 mils of fluid and see whether that makes things better, and you can be dynamically assessing that at the bedside, which is what ended up happening with this patient. I think their presses went down and flipped them onto something that's not as beta adrenergic and things like that. So where we can be a little bit more like accurate with where the site of the obstruction is. As I mentioned at the beginning, there are different types of obstruction. It's not all about you know, obstruction at the LV outflow tract with SAM. I like to always say here, it's not all about SAM. But he's not here to in any way hear it. But anyway, makes me laugh. And you can have like intracavity obstructions, which can be at the apex or the mid cavity. And these have, so this might be a patient, for example, with like mid-variant HOCM, and they get this sort of, they can get this aneurysmal sort of apical pouch, if you like, and they have some classic spectral Doppler profiles called like lobster claw ring. I'll show you some pictures of that. And then generally these intracavity obstructions, they tend to look, rather than that sort of saber tooth or dagger shaped profile, they tend to be more sharp and late peaking, and I like to think about these as more of like a stiletto heel. That's what they tend to look like, these intracavity obstructions, and they tend to be, not always, but they tend to be lower gradients than LV outflow tract obstructions are. So different sites of obstruction. I think we see a lot of intracavity obstruction, you know, in our patient groups. If you look for it, you see it all the time. So this is just, I guess, summarizing what I just said. So the LVOT obstruction, it tends to be smoother, like more gentle, I suppose, that late peaking saber tooth or dagger shaped. The velocity tends not to be more than 5 meters per second, but when you've got a really severe outflow tract obstruction, it can be. Mid cavity is that sort of stiletto heel, really sharp. You'll have probably, I'll show you some pictures of this. You've probably seen it all. More like this sort of pattern, like a stiletto heel. And it tends to be lower velocity than your LV outflow tract obstruction. And then MR classically tends to be, obviously it starts early and it ends late, so it covers that it's pansystolic, that pansystolic murmur, as opposed to AS, which is ejection systolic murmur. So it includes that the isovolumic periods, and classically it's parabolic, but you know, SAM-related MR can have that sort of late peaking dagger shape appearance to it as well, but and can make it hard to differentiate. However, the MR will always include that isovolumetric relaxation period as well. So it'll always end a bit later than a LV outflow tract obstruction trace. And MR tends to be more than 5 meters per second. So there are a few things you can use in terms of the shape, the timing, the isovolumetric periods, as well as the velocity, to help you differentiate between MR and dynamic outflow tract obstruction. And this is quite a nice, I think, diagram showing all that from an paper from ages ago now, 95. Mid cavity obstruction here in D. C showing that MR shape, and then the point here at the outflow tract, B showing that late peaking dagger shape. So there was a study by Michelle Slamer's group that looked at over 200 patients with septic shock, and they found that I think 22% of them had this intraventricular obstruction. So, you know, the obstruction within the ventricle, and it was associated with fluid responsiveness. And it was also, I mean, it wasn't powered for that, but it was also associated associated with a higher risk of dying as well. But yeah, so if you see this in your septic patients, they are very highly likely to be fluid responders. Obviously, clinical correlation is important. Any questions about that? What have we got here? Sorry, I haven't been over this. What am I trying to show here? So this is how we would do spectral Doppler, right? To try and find your gradient. So you've got your 2D, your suspicion, and now you're trying to actually do it at the bedside. So you will have your 5-chamber or your 3-chamber, whichever one you can get. And you will see that color, put your color on to direct where you're going to put your continuous wave Doppler. And then you'll drop your continuous wave Doppler through that and see if there is obstruction or not. So you're looking for that dagger shape, that elevated gradient, which we can see here. And then what we tend to go on to do is what we call drive the sort of pulse wave Doppler sample gate down through the ventricle to your outflow tract and find where the site of the obstruction is. And I'll just show you how we do that. So you can see here on this side, I haven't shown all of the steps, but what I've done is have the pulse wave Doppler on, and you can see that because we're at much lower velocities here. You know, at the bottom we're only at 2, whereas here we're at sort of, you know, you can go as high as you want with continuous wave. And that's obviously related to the Nyquist limit and pulse repetition frequency. So your Nyquist limit is half your pulse repetition frequency. So basically you need to be able to sample, you know, the ultrasound pulsing needs to be able to sample that particular ultrasound wave twice, unless it can't figure out where it's coming from. So if it isn't able to sample it twice, each cycle twice, then you get aliasing. So it's a bit like in those old movies where you couldn't really tell what direction the wheel was moving because you weren't sampling quickly enough. That's aliasing essentially. When you go over your Nyquist limits, that's what happens with pulse wave Doppler. So as you put your cursor, your sample gate, you know, start at the apex and then just drive it down the ventricle, hitting pulse wave as you're going down, you get different pulse wave Doppler traces, and then the point where you see the trace like alias off the screen, so you lose it from the bottom there. I'm not explaining this very well. I'll show you some more pictures. That's the point of the maximal obstruction. Let me see if I can show you that. Yeah, here. So you know, from this patient, you would start with your little sample gate here. Can you all see my pointer? The little finger. And then I hit pulse wave, and you can see you've got an obstructed stiletto heel looking trace there, but we haven't aliased, right? We're still, you know, not a super high velocity. And then as I come down into the mid cavity, I've still got that sort of sharp dagger shape, but we're at about 1.5. And then as I come down around this sigmoid, where the site of the maximal obstruction is, then we're going to get that huge sort of drop off, and we lose the end of the trace because it's aliased and it's wrapped around. You can see it actually coming back through here at the top. So you get that aliasing of the pulse wave Doppler, and that can tell you where the site of maximal obstruction is. Does anyone know what's happened here? They love to put things like this in the DDU exam, actually. So what happened is we've got these, can you all see these ghosting gates in red? Yeah, so pulse wave Doppler is on, but you can see we're at sort of 3 meters per second, right? That's way too high. You usually can't get past 1.5 with pulse wave Doppler just because of physics. Obviously, it depends on the scale you've got set and the depth that ultrasound beam has to travel to get and back to the probe to give you the signal. So if what the what the machine will do is it will put in these ghosting gates to try to allow you to have the scale up there. So the way that I would then get rid of these ghosting gates is by reducing this scale from 3, to 2 or something, and you actually see, as you're turning down your scale, you see the ghosting gates turn off. And the reason why this is important is because it gives you get range ambiguity, like you don't know where you're sampling from. Is it the first ghosting gate, the last ghosting gate? And so you just it allows you to be a bit more precise with where you're sampling if you don't have the ghosting gates on. You can move to like a high pulse repetition frequency mode as well to allow you to have higher velocities with the Doppler effect and things without aliasing. So you can, and you'll see that on your machines, like that high pulse repetition frequency setting. You'll see the sonographers use that. We've got another patient. Maybe for time, I might just quickly go through it. So we had a 48-year-old male, septic shock and escalating NORAD requirements. Was on 52 mils of double strength NORAD. Was on vasopressin and was just holding on with his mean arterial pressure. You can see this is a very terrible image, no ECG dots even attached, but we have a very small cavity, very hyperdynamic. There looks like there's crowding at the LVOT. Dynamic RV, can't really say much else really. It's a terrible image. In this attempted 4-chamber, again, we've got this small LV cavity. Looks like there's cavity obliteration. Again, you get the suggestion that there's maybe a bit of like thickening of the mitral leaflet, the anterior mitral leaflet. It looks like it could be crowding, and I do slow it down, like when I'm scanning as well, just to see, whether it is in the outflow tract. And it looks like there is crowding in the LV outflow tract there. So you're suspicious that you could be dealing with LV outflow tract obstruction in this context. We'll put on some M mode in the parasternal long axis. Guys, are you all right with me talking? Isn't it? Yeah. I'm not annoying you too much. Okay, good. Sorry. And you can see that in systole. So we know, I haven't got the ECG leads on, but we know it's systole because we've got the septum thickening here. You can see that you just get the suggestion there that in systole, you've got the anterior septum moving towards the anterior leaflet moving. You've got SAM happening. So that's M mode's good for that. When you've got terrible images, it can really help you out. Popping some color on. We've kind of got aliasing throughout the whole of the LV. I'll just slow that down and show you, but you can see that there's, sort of turbulent flow throughout the whole LV as well as the outflow tract. And then continuous wave showing that dagger shape, late peaking profile, all kind of in keeping with some obstruction, gradient of about 43, and then driving that pulse wave Doppler gate through, starting at the apex, working down mid cavity. You can see there's obstruction, and then there's the site probably of more of a just at the, as you're getting towards that proximal LVOT, that's probably the site of maximal obstruction. So she was given 500 mils of fluid. I think there was already some blood ordered, so she got some red blood cells and switched to give her a few aliquots of metaraminol, just as a pure vasoconstrictor. And this is amazing. So her gradient reduced almost instantaneously, and yeah, went down to 16. The NORAD went down. We cranked up the vasopressin. Can't remember if we added anything like a phenylephrine. Maybe we put her then onto phenylephrine. I can't quite remember. It didn't last very long actually because she was really septic, and she ended up like obstructing again and all of that. But certainly it temporized things for a little bit. But obviously you can't keep going giving 500 mils of fluid. You need to start looking at other parameters, right? So what the left atrial pressure is doing. Whether you're starting to get a bit of RV dysfunction, and look at your venous congestion markers, obviously clinical exam, biochemical stuff, and integrate it into your clinical practice. You wouldn't base anything just on echo, but it certainly can help you fine tune the management there. what was that? Oh, and this was just showing what happened to the pulse wave Doppler as well after that fluid and metaraminol. You can see that there's no longer, as impressive obstruction throughout the LV cavity as well. So this is generally the principles which I feel like I'm preaching to the choir definitely with all of this, but avoiding catecholamines, maintaining their preload, maintaining their afterload. So, anything that drops afterload is obviously very bad in this situation because you're going to increase that drag force on your anterior mitral leaflet. Through the Venturi effect, you're going to increase that drag across and making everything worse. So things like balloon pumps are terrible in this circumstance. And, sometimes if you've got a big anterior MI with a balloon pump, just if they're getting worse, always think about this. And maybe that balloon pump actually needs to come out because it's making things worse. That's happened a couple of times. Avoid any tachycardias and arrhythmias and things. The sort of principles, and obviously treat the underlying cause as best you can. It's generally the goal. So I think, Zoe, you mentioned about beta blockers. I don't know, they always make me super nervous, and then I don't know, always controversial topic, isn't it? But this is not my patient actually. I think it was one Sam was looking after. Had some high gradients around 4 meters per second, so pretty high, and then they just got 2 milligrams of metoprolol, which reduced the outflow obstruction. I'm not sure how long that lasted. Maybe some people do try, so maybe some esmolol and things like that. But what did they use in the trial? It was Landiolol, wasn't it, with the septic shock and beta blockers? I don't know. I'm always a bit nervous about beta blockers in septic patients. So a little bit of a change of topic, a bit of segue back into HOCM. So what are some of the things that we can do? We've got our medical management that we can do in the ICU, but if you have got someone with HOCM and you're basically not able to move them forwards, I'm talking about critical care patients here. Obviously, there are outpatients, and this is kind of what this is designed for, is a sort of a blueprint of things that you might consider in the outpatient setting. I'm extrapolating it, but if you've got patients, that have got HOCM decompensated and you're struggling with them, it's definitely worth getting some opinions from experts, cardiologists, cardiothoracic surgeons, about whether you can offer things to that patient, like myectomies or ablation. And these are the kind of things that they think about, patient shared decision making and things, depending on whether they do alcohol ablation versus like myectomies and things. So a few tips for differentiating the LVOT obstruction from the MR jet. As I said, it's not always easy. This is a patient who we had in our unit about 6 months ago, longer than a year ago now, who had lots of gradients. She had mid-cavity gradients, which you can see here, LVOT gradients, which you can see here, and then we've got that parabolic or slightly sort of late peaking-ish MR jet in the background from SAM-related MR, with gradients across her LVOT of about 74. She was really sick. I think I've got her full case, which we can try and go through if we've got time. So this is what I was talking about, that the timing, the shape and the velocity can help you. But I like to scan in real time and really sort of fan through where your MR jet is. And it's what they've done here in this ASC guideline. And you actually just move the probe real time through your MR and then all the way around your LVOT tract, and you'll see the trace change. So you can see we've gone from this pansystolic MR jet parabolic to our dagger shaped ejection, like it's late peaking, not including the isovolumic periods as well. The velocity is lower than the MR jet, and it's got that dagger shape to it. Not always as easy as that. Some more cases from our unit. So this patient, I think, is the one that I just showed prior, but she had HOCM and decompensated HOCM with probably some sepsis. She was on long-term steroids for interstitial lung disease related to anti-synthase deficiency. And anyway, she was on long-term steroids. She got PJP infection, decompensated with her HOCM, and was in a whole heap of trouble, cardiac arrests, and really difficult to manage with hemodynamics. This is us scanning through the MR jet, which we can see here. And then we've got this classic, like beautiful textbook stiletto heel, mid-cavity obstruction or intraventricular obstruction. You can see the velocities are much lower than the MR jet, and you've got that really sharp stiletto point. And then scanning in real time, no longer capturing that MR jet coming around there, but now going straight through your LVOT, and we've got that late peaking dagger shape, which is still very, very high. I think this was just after some adrenaline, after a cardiac arrest, actually. So gradients of around 140. We might be still catching a little bit of the MR there, but you were able to, in real time, see the difference between them. So when they're superimposed, it obviously makes it tricky. This is just showing an example similar to this real life one here, but in the ASC guidelines. So here you've got the MR jet superimposed LVOT obstruction trace on top of that. And then by going to a different view and sort of fanning around, this is your actual LVOT profile with it hidden within this one here. This is what I was talking about with the apical HOCM. I was going to quiz you on what this might be, but this is what it tends to look like. You get that Ace of Spades sign. You got this apical pouch happening, and this is just showing it on in cath as well. And then what happens is, because you've got this, you get this interrupted cessation of flow. So as you've got this forward flow out of the ventricle, it completely stops abruptly because of the cavities obliterating, and then you get emptying, and then it opens, and then you get emptying of the pouch again. So it looks like this lobster claw appearance with Doppler. So actually, I might skip this case and see if I can show you. Oh, I've got too many. No, I don't want to show you these ones. Sorry. Has anyone got any questions? I'll just try. I think I've put a case at the end. Yeah, I've got a little case here to show you that one of you might want to practice. Do you want to practice some Viva practice, anyone? I think this is the one. Yeah.
Yeah, I mean, I'd be happy to
Oh,
try
you
again
want
if
to
no one
practice?
else, but I've already had a go, so.
Who else is on that? You don't have to, guys, but it's if you're keen and willing. You're good, Hewan? You want to take this on? Yeah. Oh, I'll have to get. Sorry, I'll need to sort this out. I'll keep playing.
No, that's all right. Yeah, so there's no clinical history, but so it's a parasternal long axis.
Sorry, so the clinical history is
sorry, here it is. Yep.
67, just came to the ICU, acute renal failure, pulmonary edema, systolic murmur. She actually, when she was admitted, we didn't know she had HOCM. It wasn't until we subsequently got her notes. This is all we had at the time. Super sick with escalating NORAD requirements, background of hypertension. And she had this anti-synthase deficiency as well, and interstitial lung disease. Actually, quite a lot missing off that, but yeah, I think we simplified it for the exam. Anyway, this is what you got.
Yeah, I think the salient features are like hyperdynamic LV function, and subjectively there's a concentric hypertrophy, and I think I saw some MR jet as well in the next image. Yeah, so posteriorly directed MR jet here, and because it's a HOCM talk, I'm worried about this being HOCM.
You can bag this out as much as you want. It's not the best, is it? Anyway.
Yeah. So again, like this 2D measurement. Look, again, it's a diagnosis of exclusion, but there is like an interventricular septum greater than 1.5 centimeters. Yeah, so consistent with, which could be consistent with diagnosis of hypertrophic cardiomyopathy.
She also has renal failure and hypertension as well.
Yeah, so, I mean, looking at aortic and mitral valve here, I think there's sort of I think there is, I'd call that significant echogenicity, likely calcification, given the clinical history.
Yeah.
Um,
what would you call that?
So that's probably just MAC, mitral annular calcification.
Yeah, posterior MAC. Yeah.
Posterior
Mitral.
MAC, yep.
Yeah.
But also in the aortic valve, I
Yeah.
get a sort of suggestion that there's probably calcification there.
Very nice. Yeah. What about the color across that?
Yeah.
Sorry.
No, it's all right. I mean, I see some aliasing, but I'm not quite sure what to make of that color Doppler.
Yeah, and it's probably not the best. Like, it's a bit small. It's a bit too far up, isn't it? You'd want it to cover more of the LV outflow tract as well. Yeah, it's not. I agree with you. It's not the best color Doppler, but you do get the impression that you've got this height. Yes, so thickened ventricular walls, crowded LV outflow tract, some calcification of the aortic valve and mitral apparatus, and the suggestion of maybe some SAM happening as well. But you need to see in more windows. Just for time, Hewan, I'm just going to go through this just to get you onto that. But the aortic valve is calcified and there is restricted opening of that aortic valve as well. Okay, let's get on to this one. Oh, damn it. Sorry.
All right.
And they're playing. I'm just going to do it manually. We'll start up here with this one. Sorry.
Yeah, so that's sort of hypertrophied hyperdynamic LV at the papillary muscle level. As well as the apex. This is parasternal short axis at the aortic valve level. Again, like significant calcification of, I think, like the trileaflet aortic valve with significant calcification. And I think, I'd like to have a look at other views, but like probably the non-coronary leaflets, like restricted, but maybe I'm making that up.
Yeah, it's a bit hard to see, isn't it? It's not the best, but yeah, I mean, you do get the feel that it is a tricuspid valve that's heavily calcified, and probably there's a degree of aortic stenosis, and you'd want to better quantify that. Don't know what this is showing. All right.
Wow. So on 2D, there's severely dilated left atrium. Again, mitral annular calcifications. And I'd like to look at color.
Can I just try it? Sorry. I'm sorry. I added this in like the last second, and let me just do that. Do that. That looks better.
Yeah, nice. There is likely SAM on that top right-hand image, and the bottom, the color Doppler. Yeah, I think there is posteriorly directed MR jet, and just look based on color alone, I think I'd classify that as severe.
Yeah, very nice, Hewan. Yeah, it's so just to slow this down for everyone as well. So we've obviously got this small LV cavity, hypertrophied, prominent sigmoid septum as well, and then this septal contact, or SAM, that you can see happening there when you slow it down. It's probably the anterior mitral leaflet as well as the cords as well. So, lots of obstruction through that LV outflow tract. There's also mitral annular calcification. And we often see this in renal patients where they have, and chronic hypertensives, where they have, some MAC as well as some, aortic valve calcification as well, which is you can see with this lady. And again, that's just demonstrating that there's suspicion around this area. It's a 4 chambers, you can't really see it properly, but abnormalities with that mitral valve as well. She actually had calcific MS. It was only mild. And I think that's why we're seeing like a little bit of sort of like there's a bit of centrally directed MR as well. But it does, I agree with you on this one. It does look like you are getting that eject, obstruct, leak posteriorly directed SAM MR as well. But she was really complex, this lady, because she did have some calcific MS, which was mild, and some, I think, it was hard. I want to ask you about this actually, but she also had a calcific aortic valve as well with restricted opening. What does this show?
Yeah, so it's a pulse wave Doppler at the sort of a mid cavity level, showing sort of late peaking jet with a peak gradient of close to 2.5 meters per second, which would make it just above 20 millimeters of mercury.
I'm not as good as I'm not as good at math. I'd have to have a bit of time to think about that. But yeah, it looks a bit elevated, doesn't it? And obviously the shape gives it away. What's this one showing? We've actually already shown this, but yeah, practice describing.
That's probably the that's a continuous wave across the, I mean, somewhere between the mitral valve and the LVOT. I see a parabolic wave, a higher velocity waveform, which is probably the MR, and that late peaking jet with the lower velocity, which is the obstructive waveform.
Yeah, this is probably the intraventricular waveform, I think, like along the LV, and then this is the MR in the background. And then as you sort of work your way through this one, it's a little bit hard, but it's not fully, the timing of it suggests that maybe it's not fully extending out to the isovolumic times. It's more dagger shaped than the parabolic MR that we're seeing here. And in real time, I've got a video showing this. In real time, you can actually see that flip from the MR trace around to the dynamic left ventricular outflow tract obstruction trace. And there's nothing that replaces that dynamic scanning here, actually, to differentiate them. Yeah, so putting it together, I might just skip that. Just for like bonus points, what does this show? What might this be?
Lung ultrasound showing confluent B lines. Suggestive of interstitial pathology, but in this case, pulmonary edema.
Very nice. I might just skip this one. Oh, yeah, I'll show you the IVC actually. Yeah, just see that with a bit of colour.
Yeah, I mean, it looks like plethoric and it's non-collapsing. And this is pulse wave across the hepatic vein. I mean, there is probably systolic blunting. Yeah, there's systolic blunting.
Yeah, there's nothing happening forwards in systole, is there?
Yeah,
it's like purely diastolic flow. What might that be telling you about what's happening there?
That's just raised right atrial pressure.
Yeah. So really this was just after her cardiac arrest actually, and she'd had adrenaline and things like that, and was intubated, and like her conditions were so dynamic, so you need to repeat it. But yeah, it showed this like predominant diastolic filling, really, really sort of restricted filling on the right side, with high right atrial pressures. Very nice. Can everyone see that? So you've got systole here, you've got no forward. So normally you would have your forward systolic flow, which is predominant as your blood is flowing in systole from your hepatic veins, filling that right atrium. Ready. So it's nice and full, ready for diastole when that tricuspid valve opens. So in systole, it's coming forward into the right atrium, and then you get some filling in diastole, but your S wave is usually bigger than your D. And then as your atria contracts in diastole, at the end of diastole, you get that AR reversal. You can sometimes in like textbook cases in between the S and D see like a little V wave, as it sort of just reverses back during ventricular systole into the hepatic vein, and then you get your diastolic forward flowing diastole, and then as I said, as your atria kicks, you get this AR reversal. Usually what we see is your RV becomes, you should get high right ventricular end diastolic pressures or raised right atrial pressures. What you normally see is this sort of increase in your AR wave. That's you can imagine that as your atria is contracting, but you've got really high pressure in there, and you've got this restricted RV,
That's okay.
with diastolic dysfunction of your RV, you know, you're going to have a more of a flow back into the hepatic vein after your atrial kick. So that's what, and then what you see is blunting of your S wave, and then eventually you will see full diastolic flow. If you've got severe TR with that as well, you can then see systolic flow reversal, where you get this sort of sinusoidal pattern happening, signifying, you know, severe congestion in the context of severe TR as well. So a lot of information that you can gather from that. And what does anyone know what this shows? What vessel we might be looking at? It's not the best, but
Is that a portal vein flow? Part of your VEXAS assessment?
nice. Yeah, very nice. What does it show, Zoe?
It's so normally you should have like essentially a flat line with a little bit of pulsatility, but I think this is an extreme case of congestion where instead of pulsatility you're getting flow and no flow.
Yeah, really nice. Really, really nice. Yeah, I mean, as I said, this was just after she'd arrested and had adrenaline and been tubed and had a fair bit of fluid. But so how does this, so if you can you summarize your findings, Heyman? I'm going to leave this part out because I think that's mean of us to put that in as well. Just with what you've looked at so far, how would you put this together?
So I think the sort of the salient features are so likely sort of LVOT, likely a dynamic outflow obstruction at the LVOT level due to SAM, and also at the mid cavity level in this lady who has an underlying diagnosis of hypertrophic cardiomyopathy, but there are also and also complicated by posteriorly directed MR, and the gradient of the LVOT gradient is significant. But there are also other coexistent valve pathology as well, as you pointed it out, including calcific mitral stenosis and possibly aortic stenosis. I'm not quite sure how to put the raised right atrial pressure together in this though. It could just be due to very high left atrial.
I agree with
Pressure?
you. The right atrial pressure. So she actually, before she arrested, she didn't have congestion on the right side. That was all like following the arrest and stuff. But now you've got evidence of pulmonary congestion. This is after her arrest. You've got pulmonary congestion. You've got systemic venous congestion in a patient that has a heart that looks like all of this, right? So how complex, right? You've got someone that's got this hyperdynamic obstructive LV, you know, as well as having pulmonary edema, as well as having systemic venous congestion. So she was very, very, very tricky to manage, because you almost want to, you know, you don't want to give her any more fluid because she's already looking like she's congested now on the sort of, you know, on the systemic venous side of things. You know, that fluid for the SAM related MR and the pulmonary congestion might make things actually a bit better for that. But you are in a little bit of a catch-22, and it's quite tricky. The other question that I want to ask you is, how would we grade her aortic stenosis? Can we grade it? Like, is there any way that we could grade it in the context of having, so she's got a dynamic outflow tract obstruction as well as having a degree of fixed aortic stenosis. Can we just use our usual assumptions? And
I mean, you have to, I mean, maybe this is a very surface level answer, but you probably have to use that, the modified Bernoulli's equation, because the proximal velocity is so high.
Yeah, very
But
nice.
I mean, yeah.
So yeah, I mean, the textbooks say if it's more than, is it 1.5 meters per second, that proximal velocity, then you need to obviously correct for that and take that off. But I think that would be really tricky to do in this circumstance. And it was just, yeah, it was, I mean, I don't think you can confidently say that what the severity of the fixed aortic stenosis is. There might be someone that can answer that well, but we ended up just saying significant fixed aortic stenosis, which is hard to quantify currently in this dynamic setting. And sort of left it at that and tried to manage her hemodynamics as best we could, which included trying to, not give her any more adrenaline, give her vasopressin and really try and limit the noradrenaline as much as possible. I think she was started on phenylephrine. We didn't go for beta blockers. And then we were just like really cautious initially. I think that first night, I wasn't primarily looking after her, but I was there to do the echo and stuff. And just gave her little aliquots of fluid, just being careful with PEEP titration and things like that. And just paying a real attention to preload and afterload conditions and things. Yes. Any questions about that? I'll not go into what ended up happening and go through all that stuff. We might end it. I can't seem to finish in an hour. I never finish in an hour. So I appreciate you all sticking around. All right.
Thanks, Emma.
Thanks,
Appreciate
Emma.
it. Thank you.
Bye. See you next time.